electronic and Jeremy. I know that I can speak on behalf of all of the people who are attending today. We learned quite a bit, and we're excited to see that there are questions coming in that we'd like to address. Most of the questions really deal with the practical, hands-on, what do you do in the primary care setting or in the other settings where we might see these patients. So the first question is about what happens when the child does disclose suicidal to ideation, feels like life isn't worth living, and then when you mention it to the parent says the child is doing it for attention. How do you handle that?
This is something that we unfortunately do deal with on a regular basis in our emergency room. I think there's a couple tiers to this question that I'm going to try to address. The first is sort of concept of doing it for attention. I think sort of providing physical education to families that kids, really do kill themselves, and this is actually a likely possible thing that could happen, and that why we take it seriously, but also that kids tend to be better understanders of how they're doing for mood, and we were talking earlier about the internalizing versus externalizing symptoms, that children tend to be better arbiters of the feelings of their thought, and well, he just went to band yesterday, or he was just playing with his friends, or he seems fine. A lot of kids who seem fine, unfortunately, do kill themselves, and I think that's an important bit of information that a lot of times parents don't have. Similarly, kind of go back to the first half of the question, when people sort of don't have a plan, they're sort of not truly sensitive to ideation, really kind of sitting down with the patient and family, like family was talking about this sort of safety planning, no access to pills, over-the-counter, and prescription. As physicians, I think we often know that the over-the-counter medications can be just as dangerous as, or sometimes more dangerous than prescription medications. I think a lot of the families, what's the big deal if there's a giant bottle of Costco-sized extra Tylenol in the bathroom? And sort of limiting access. What we know about suicidality is that a lot of these attempts can be impulsive, and not that they're not planned, but often in the time right after an attempt or the time right before, if they're given an extra chance, things have to go through the process. A lot of times that's able to avoid a suicide attempt. So you really want to make it difficult for people to have access to things they might use, whether it's sharp objects, knives. A lot of families first the idea of locking up all their knives, especially their kitchen knives, but sometimes that's what's required, making sure there's extra adult supervision, and then really limiting access to firearms completely, and if a patient is on medication, maybe failing access to a few days of medication at a time, and the parents are going to refill the bottle every 3 to 5 days. The importance of getting into care, and establish and follow that safety plan, and if they're not interested in sort of any sort of higher level therapy on outpatient, so we talk about getting them into therapy, starting them on an SSRI, primary care, getting them in with mental health providers as possible. If they don't feel like they can kind of revise that safety plan and just sort of get that pit in your stomach and feel like there's an secret, certainly either calling or on-call social work to discuss the case, or possible referrals to any other could be in play at that point.
Yes. Another question is around the practicality of screening. And we all know about HADS and SHADS. In primary care, we know about HADS and SHADS. And that's part of our adolescent well-child visit. But what we're hearing from you is that this is happening a lot. This is an increased risk for kids with chronic diseases. And they may be seeing these specialty clinics a lot more than they see in primary care. And that the symptoms that our kids are presenting with, and I know this from my personal experience with patients, might be abdominal pain or headache. So I guess the question I have is, in those situations, we're not doing HADS and we're not doing SHADS, whatever you want to call it. And so I guess the question is what you do. And then to top that, when you think about the fact that suicide is now down to children 10 years old, 11 years old, we're not talking to them by themselves. That's not something we often do in primary care. And for those, even in well child visits, we're not doing heads and chest. So I'm just wondering if there's new thoughts about how to get at this issue through our typical ways of seeing these patients that are coming in, and what you've learned from the emergency department that we could apply to our specialty clinics and primary care sites.
I would say seeing these patients in the emergency department at least, so we see a lot of patients with these chronic illnesses, and then ultimately we do find out that they screen positive for severe depression or suicide risk. So it's important to realize, like we said earlier, that these chronic illnesses are at risk for depression and may be missed. And if they're not followed by, and if you're not asking about it in primary care, we do see some patients. I've seen examples where patients who get diagnosed with a concussion, for example, they continue to have concussions for weeks or months later, then we realize that maybe there's something else going on. And we actually talked to some sports medicine orthopedic specialists who have actually started screening themselves. So we are encouraging that if you do have a concern in primary care and the patient is followed by someone like hematology or GI, maybe reaching out to their subspecialist. And we're trying to do our part by also communicating to the subspecialist as well from the emergency department. And then for the younger kids, it is a little bit difficult. So we often don't do the screening. So the screening in the emergency department is for 14 years and older. Sometimes we'll do it in 13-year-old patients. But it has been validated that particular screening in patients at 14 and older. But we still will talk to patients alone sometimes the early teenage period. And if you're not able to talk to the patient alone, I still would have that conversation that I was mentioning previously to parents, maybe talking to the parents alone, talking about general risk, the state of depression that we're seeing, that even though we're not labeling their child as having this, we take it very seriously and really do want to pay attention to certain things. Ask about some of these bullying or internet use, especially since younger children have their own phone sometimes or on an iPad. So if you do notice that your patients are using the internet a little bit more at a younger age, thinking about that and contact has anymore.
I think I come from a different viewpoint too, being a child psychiatrist, but I think we're moving towards a world where recognizing that the issue that this isn't how young you go, that screening is going to become the norm. And there's been a lot of zero suicide initiatives at CHOP and other places to really work to eliminate child suicide. And there'll be some exciting things that will have suicide in the future. So familiar with that group, and I kind of sort of sitting here and there with them, they're really kind of pioneering it. They're really pushing forward about universal screening, and I think we built things into EPIC and into our charting and finding schemas that not necessarily happen even during the physician time, but that can happen in different ways. We understand the sort of the punch, the difficulty in sort of adding one more thing into you already did the outpatient system. I think what we say is this is something that is extremely important, and during the subspecialty types of screening, you're not having graduates coming in regularly into the actual performance compensation. I think it's vitally important and possible question.
So I think that what I'm hearing is there might be some screening coming that is more universal, but in the meantime, it's a high index of suspicion. And to really remember those risk factors and ask about suicidal ideation and just make it routine that that's something you do, but also know what to do when you have that information seems like the plan. But I know that we practice in my primary care practice. So another question came in about finding high-quality mental health providers that take insurance in Montgomery County area. Any thoughts about how to help families who can't pay out of pocket?
So, yes, this is always sometimes $1 million question in terms of finding mental health providers. There's part of why I wanted to talk about the need for primary care to get back into the habit of prescribing exercises. That we kind of have about 7,500 child psychiatrists in America, and the CDC expects by 2020 we need about 20,000. So there's a shortage, and we know that it's hard to get people into psychiatry psychiatry and therapy. One idea that is important to learn, so you call your insurance company, see the providers are local agencies to prescribe or not, but you can see the patient that's covered under insurance. A lot of insurance people also have out-of-network benefits. The way this works is you can both the out-of-pocket and outside therapy or psychiatry will have their rates. Often when you look at a site, bill rates for families of less needs and services. And you can call your insurance company, see what your out-of-network benefits are, and that essentially every time you see your mental health provider, you get a receipt and you actually submit the bill on your own to your insurance company. Get reimbursed from your insurance company. And so for a lot of families who they don't have providers nearby that can actually see them or are available, they can actually get in with these out-of-pocket providers to actually have most, if not all of their sessions covered. It does require an extra bit of legwork with that. I understand that that's not something that's feasible for all families and for all home situations where people may or may not have the wherewithal to do that. But it is definitely an underutilized way to go around the approaches we have right now in terms of access to mental health.
One other really quick question is about privacy in the adolescents, and particularly as adolescents who are moving on to college or away from home. What do you do in a situation where the adolescent discloses something to his provider and the parent isn't around? I understand that if there's a need for if there's homicide or suicide risk, we're required to tell them. But how do you do that on the phone? What do you do? How do you tell the family that your child just disclosed something? What do you do for that?
I think first and foremost, you have to have that conversation. Sometimes either it's on the phone, it's asking them to come in and see how quickly they can be there if they're nearby. But I think it's not a conversation that you shy away from. I think first and foremost, you're having the conversation, however it may be. The conversation might be, hey, I need to send your kids in the emergency room. And I think families going to want to know why, and that conversation has to be great. On the flip side, in Pennsylvania, if you're over the age of 14, you do control your own mental health record. And that means you can actually consent to your own mental health care. So if there is a patient you have that is 14 or older and that wants to go see a therapist, they can actually consent on their own to their own evaluation and treatment. I know this kind of makes sense a little more in the city where kids can get on public transit their own or kind of get their own way to care, but also for your older adolescents who now have the driver's license and can drive themselves to their college age for sure. Most colleges have a mental health center on campus that can also help you get access to care or provide counseling and other mental health services on site. But generally, it's important to sort of have the patients themselves know they can get care even if they feel like their parents be sort of an impediment or give you some pushback if there's anything self-important. Have to talk to the parent as long as the child is outgoing. Obviously, suicidal suicidality, you need to create confidentiality, but for things that don't meet that criteria, often do encourage the kids, like, let's have a talk with your parent together, let's sit down together and discuss this. So I think it's going to be important for them to know. And usually kids are pretty amenable to that.
There's one last question, and I understand it's going to give us a lead to get back to your patients, but I really would love to be able to answer all of our questions here, and this is the last one. Your thoughts about a workflow where screening occurred as part of a previous assessment that was forwarded to patients in advance of their visit, possibly using my shop as a vehicle to deliver the screen. What are the challenges and advantages? Are we even considering this?
So I would say, as far as thinking about workflow, it's great to think about how you could incorporate screening into your practice. I think the biggest challenge with this and how it can be dangerous is that if you do give a screen prior to a visit, if the patient isn't in your office yet, and the screen is positive for depression or, more importantly, current suicidal ideation, the patient doesn't show up at the visit, then that's a big challenge. So I think that's a little bit of I would be hesitant to do a pre-screening visit outside the emergency room. We do give screenings during their visit, and it hasn't really challenged or increased our length of stay or left without being seen, right? So it's feasible, just thinking about how you can think about it, at least in the future.
I would just also add the issue with a pre-screen that first sent home is what happens and what symptoms would you need to wait if a kid filled out their suicide risk assessment at 3 a.m. and whose inbox is it pinging that the kid says they have the active suicidal plan or something of that nature. There's a lot of challenges, I think, to that design. Certainly with a model like we have, you could try to work through some of them, but I think it would be difficult.
Thank you very much. This concludes today's webinar. We ask that all attendees complete the online REDCap survey that will pop up when we end the webinar. As a reminder, if you would like to claim AMA Handy credits for continuing education, you're required to complete the survey. So I hope you all agree with me that this was a terrific, engaged group of participants and presenters. We really appreciate all that you do to protect and enrich the lives of children. We hope this webinar was useful and actionable for you. I also want to sincerely thank our presenters, Dr. Esposito and Jonza. Please remember to take the time to complete the survey that will pop up when we end the webinar. Feel free to contact these presenters afterwards if you have additional questions. And at this point, we're ending the webinar. Goodbye.